welcome back after a gap of 2 months. I'm sorry for that, but then a lot of commitments, conferences, Diwali, and so I'll adequately compensate for that, right? So I really love the enthusiasm with which you all join and you know be with us. So, and you have, I think all of you have seen that conference slide. Before this slide that was being displaced. So that's the Eco India to be held in Delhi, this time Gurgaon. All right, from 8th to 11th October. And you all need to participate with with wholeheartedness, large numbers, and you will not repent attending it. Okay, and all those who want to present their cases, be ready with your cases because this time we will freeze the cases earlier, okay, rather than just waiting till the last time. So keep finding out good cases, whatever is coming across, and do let me know whoever wishes to present. Right? We keep sending you mails and WhatsApp messages. So we will send you an invite also accordingly, and you can submit your cases on that. Right? So let us start thanking our moderators and Dr. Rakesh Gupta for again instigating me to restart this session after a gap. And I especially thank Dr. Rohit Tandon for coming and joining us today and helping me out at the last moment. And we'll be talking about the importance of velocity time integral in eco evaluation. Our listeners are it's a mixed crowd, I'm sure, and many of you must be knowing about this VTI. But actually, we undermine the importance. And so, for everyone, we will tell what is the significance of velocity time integral, where all in what situations we can use this, and how we can incorporate this in the clinical management in the emergencies or in the post-surgical units. So this is a kind of a parameter which can be used in multi-parametric assessment of any patient. Okay, this is one of the parameters, not the only parameter, but it can be really useful in following up the patients, maybe a heart failure patient or whatever. Okay, but so as we have earlier said that please keep seeing the suprasternal window, keep seeing the this epicardial fat. So now onwards, we have to remember that we also have to keep evaluating VTI in most of our patients who look little abnormal. Okay, and when you do it in normal patients, you would come to know that how VTI helps and what is the normal pattern, what is the normal value, right? So you will remember that. I now invite Dr. Soni Rungta from Bombay Hospital Indore to, present this topic. Dr. Soni, all yours.
Thank you, ma'am. Thank you so
Yeah.
much. Good evening, everyone. First of all, I would like to thank my seniors and special thanks to Dr. Hansa ma'am for giving me this opportunity to present this slide. The topic that we will cover today is importance of VTI, that is velocity time integral in eco evaluation. Let's quickly revise what is VTI. VTI, it is a Doppler measurement that quantifies the distance a column of blood travels during a specific time period, typically in one cardiac cycle. In other words, velocity time curve representing the sum of all the instantaneous velocities over time. It is measured using a pulse wave or a continuous wave Doppler across the orifice where the cross-section area can be measured. As we can see in this slide, VTI across each of the valve can be calculated using the pulse wave or a continuous wave Doppler, and by measuring the diameter across each of the valve, cross-section area can be calculated. And the product of this cross-section area and time velocity integral gives the stroke volume. As we can see in this, the stroke volume across each of the valves remains constant in the absence of any intracardiac pathological or physiological abnormalities. So what goes in comes out. Moving to what is LVOT VTI. It's a Doppler recording which is performed using the apical five-chamber view or an apical long-axis view, and the sample volume is placed at the level of aortic annulus, approximately 3 to 5 mm proximal to the aortic wall. At this position, it is usual to record the closing click of the aortic valve at end systole. If the opening click is present, the sample volume should be withdrawn slightly into the outflow tract. Here we can see the angle of insolation, which is between the blood flow and the pulse wave Doppler. It should be less than 30 degrees. This slide shows the normal value of LVOT VTI, how it's recorded. Moving to significance of LVOT VTI.
Sony,
The,
we had some slide which was showing the aortic valve click so that they understand that, to have a proper VTI assessment, we should
okay.
have that click, visible. Is there, I think it was there in some of the
Uh,
slides,
yes, ma'am. It was there
but we
previously.
have, but we have removed that.
Yes, ma'am. That
Okay,
slide
let us see.
has.
Let us see. Let us see. So it is very important, guys, to have an aortic valve click on the trace, because that will help us to understand that we are at the right place. Because putting the sample volume at the right place is very essential. And this angle of insonation is the that how parallel you need to be to the blood flow. At some places it is 20 degrees, some places 30 degree, but the understanding should be that you should be as parallel as possible to the flow, right?
Yes, ma'am.
Go ahead.
Moving on to significance of LVOT VTI. Usually the normal value is between 17 to 24 centimeter. A quick assessment of LVOT VTI in hemodynamically unstable patients can help in identifying the underlying etiology, as it is a valid surrogate for the stroke volume and a feasible method in calculating the cardiac output, even in emerging bedside echo. Low LVOT VTI, that is less than 17, can be seen in patients with shock, where there is an inadequate tissue perfusion. Shock is usually we study of three types: hypovolemic, obstructive, cardiogenic, and distributive. We'll see how LVOTI can help us in assessing each of the shock. In cases with hypovolemic shock, which is usually due to bleeding or GI loss, there is a reduced preload, and serial measurement of LVOT VTI help assess the fluid responsiveness. If after giving a fluid bolus, LVOT VTI increases, the patient is responsive to fluid. If there is no change, then the patient may not benefit from further fluid, and an additional treatment like inotropic support should be started. Moving on to cardiogenic shock, which is usually due to impaired cardiac functions, like in patients with MI, heart failure, or myocarditis. In these cases, LVOT VTI is reduced due to poor contractility, and these patients usually respond to inotropes. So, serial measurement of LVOT VTI is used to monitor the effectiveness of inotropes in these patients. In cases with cardiogenic shock, which is usually due to sepsis, anaphylaxis, or acute liver failure, there is a vasodilatation and there is maldistribution of blood flow. And there is peripheral pulling of the blood and thus reducing the preload. So LVOT VTI guide us with the fluid management and the vasopressor therapy in these patients. In cases with obstructive shock, which usually result from the physical obstruction to the blood flow, in cases like cardiac tamponade, massive PE, or tension pneumothorax. In these cases, LVOT VTI is reduced due to impaired left ventricular filling, and LVOT VTI can be used to monitor the effectiveness of intervention in these patients. If LVOT VTI improves after pedicardiocentesis or thrombolysis in patient with pulmonary embolism, it is indicative of successful therapy or successful intervention. Uh, Moving on to raised LVOT VTI, which can be seen in patient with HCM, LVH, subaortic stenosis, sigmoid septum. Here, the LVOT VTI is raised due to narrowed outflow tract and resulting high velocity. LVOT VTI is also raised in patients with high cardiac output state like anemia, fever, pregnancy, where their heart rate is raised. To summarize the advantage of LVOT VTI, it's non-invasive, can be performed at bedsides, provides a real-time hemodynamic data, guides fluid management and therapeutic intervention, help assess the response to treatment like inotropes and mechanical supports. It is the changing VTI in response to treatment that is significant. Moving to mitral valve VTI, usually its normal value is between 10 to 18 centimeter. Pulse wave Doppler is used to record the mitral valve inflow velocity at the level of mitral annulus in 4-chamber or 2-chamber view, and the VTI determined by planimetry. As we can see in this, the MMV VTI is approximately 15 centimeter, which is normal. Clinical significance of MVVTI. It is used in assessing the mitral valve dysfunction. In patient with MS, high MVVTI indicative of reduced mitral valve area. As we can see in this, the mitral valve VTI is 70 centimeter, which is indicative of severe MS, less than 1 centimeter square. In patients with MR, elevated MVVTI and LVOT VTI ratio is suggestive of significant MR, usually greater than 1.13. Uh, MVVTI is also used in monitoring the prognosis and management of procedures like percutaneous mitral valvoplasty, mitral clip procedure, valves post-procedure functions. Also in monitoring the bioprosthetic valve dysfunctions. Moving on to RVOT VTI, it indicates the volume of blood ejected from the right ventricular during systole. The sample volume is placed just before the pulmonary wall in basal short axis view, and the waveform recorded by planimetry, which gives the LVOT VTI. Its clinical significance is that RVOT VTI, it is a prognostic measure indicating of RV function. In combination with RVOT diameter, it gives the right ventricular stroke volume. It can be used to assess the fluid responsiveness. It can be used as a bedside technique to assess the patient responsiveness to fluid therapy. If there is more than 12% increase in RVOT VTI after a passive leg raise, is indicative of positive response to fluid therapy. It can be also used in cases with to calculate the pulmonary vascular resistance. By calculating the ratio of tricuspid regurgitant velocity and RVOT VTI, multiplying with 10 and 0, adding 0.16, we will get the pulmonary vascular resistance. Usually the ratio greater than 0.12 has been used as a screening test for elevated pulmonary vascular resistance. Low RVOT VTI serve as an independent predictor of mortality in patients with pulmonary embolism and pulmonary hypertension. VTI and continuity equations. Continuity equation states that by sampling the VTI at 2 points and measuring the cross-section area at 1 point, the other cross-section area can be determined using this formula. For example, if we want to calculate the cross-section area of aortic valve, here the A1 is the cross-section area of the LVOT multiplied by LVOT VTI divided by the aortic valve VTI. We'll get the cross-section area of the aortic valve. Similarly, regurgitant volume can be calculated by subtracting the stroke volume across two orifices. For example, if we want to calculate the regurgitant volume across the mitral valve, we'll subtract the stroke volume of LVOT from mitral valve stroke volume. Here we can summarize that similarly we can calculate across each of the using continuity equation, we can calculate the area across each of the valve. Continuity equation can also be used for shunt assessment. Moving to next slide. In cases of AS, continuity equation has an advantage over pressure gradient in patients with aortic stenosis in estimating the aortic valve area, as it is unaffected by the presence of any AR or left ventricular dysfunction. In patients with severe aortic calcification, DVR can be used as one of the parameters to calculate the severity of AS. DVR is LVOT VTI divided by the VTI of the AV jet velocity. Normally, the value is between zero point 0.9 to 1, and value of less than 0.25 is indicative of severe AS, as we can see in this how it's this how it's measured. Moving on to next slide. This is another
Sorry, I
example.
just
Yes,
just interfere here.
yes,
With
ma'am.
this value of less than 0.25, of
Hmm.
course, we are able to assess that the AS is severe,
Yes,
even in
ma'am.
low gradient situation, low gradient, low flow AS also. And it is also, it suggests that the prognosis and chances of adverse events will be very, very high in such cases. All
Yes,
right.
ma'am.
So
Yes,
this
ma'am.
VTI dimensionless index is also one thing to assess the severity. The other thing is also it's a good prognostic marker.
Mark.
All right.
G.
And somebody is saying that we should be going
Go
little slow.
slow. Yes, ma'am.
Yeah. So
Okay,
because
ma'am.
to have the good concept,
Okay, ma'am.
let us go little slow because some people know, some people do not know
No.
about the thing. So let them be clear of the facts. All
Okay.
right. Yeah.
Should I proceed with the same slide, ma'am, or
Yeah, you can do that because this is
okay?
a very important thing
Yes,
everyone
ma'am.
should remember.
Hmm. Okay. So in cases with aortic stenosis, continuity equation has an advantage over the pressure gradient as it is unaffected by the presence of any AR or left ventricular dysfunction. In patients with severe aortic calcification, where it is difficult to get the this LVOT track, we can use this dimensionless velocity index. The ratio of this LVOT VTI by the AV jet velocity will indicate its value will indicate the severity of AS. If it's more than less than 0.25, it is indicative of severe AS.
I will also add upon one more thing here.
Yes, ma'am.
Dimensionless means that we are not measuring the LVOT diameter, which we usually do in measuring the stroke volumes and everything. Okay. The
Yes,
flow across, right? So when we measure the dimensions as per the formula, we are squaring it. So
hmm.
if there are measurement errors in LVOT, measuring the LVOT diameter, the error will be multiplied.
Multiplied.
Okay.
Hmm.
So, so Dr. Rohit, there's some question coming up. We'll take it a little later. Okay. Uh, all right. So, so LVOT, so this dimensionless index actually excludes those errors, and we are just estimating the velocities, velocity time integral across the LVOT and across the valve, which is possibly stenosed. Right. Go ahead.
Here is another example to calculate the regurgitant volume, where the stroke volume across the aortic valve is calculated using the cross-section area and the VTI. And similarly, the stroke volume across the mitral valve is calculated using the cross-sectional area and the VTI. The regurgitant volume of this AR can be calculated by subtracting the, which is 43 centimeter over here, which falls into moderate category. So by this, we can see what's the severity of regurgitant volume across any of the valve. VTI can be also used in cases of shunts. Pulmonary stroke pulmonary stroke volume when compared with aortic stroke volume gives the net shunt volume in the absence of valve stenosis or regurgitation. This approach is used in pediatric echocardiography to quantify the intracardiac shunts like VSD and ASD. It provides more accurate measurement in cases with dilated ventricles. Usually the normal QPQS is 1:1. If more than one, indicative of left to right shunt, and less than one, indicative of right to left shunt. Clinical significance in assessment of the shunt severity, operability assessment. For example, if QPQS is more than 1.5 or 2, indicative of surgical intervention. It is also used in monitoring the prognosis of the disease. As we can see in this slide, the QPQS ratio is 2.5, indicative of large secundum ASD. To summarize, VTI is a simple, repeatable, and non-invasive echo technique that provides a valuable information about patient's hemodynamic state. It helps guide fluid therapy, monitor response to treatment, and predict risk for patients with heart failure, sepsis, and other clinical critical conditions. Thank you.
Thank you, Dr. Soni. It was crisp, and I think we went a little faster, but
Faster, yes, ma'am.
we'll see to it. Dr.
Okay.
Vipul Garg, you are making some comments. Can you please elaborate what you were trying to say? Dr. Vipul Garg, you have messaged in the chat box. Unmute yourself. Dr. Rohit, are you here?
Yes, ma'am. Yes.
Please comment on this.
Oh,
And any
this,
more?
ma'am, many of the uses of mentioned seem to be more of academic importance. That is what has been written. But I don't think this is only academic importance. This is a very practical importance thing
Correct.
because the thing is this VTI LVOT VTI is used in emergency echo a lot. Because in
Yes.
emergency echo, when we have to see whether the patient is actually in cardiogenic shock, this is the only indicator which gives us the value, and then we can decide whether to give fluid or whether to start inotropes or whether we should only continue with whatever diuretic treatment patient is having. So I think it is not only academic; it is a very utmost practical importance. And LVOT VT is also very useful in aortic stenosis patient to grade the aortic stenosis also.
Perfect. Perfect. So I would, again, tell the audience that this topic was picked up not just because even in cardiomyopathy patients, when the VTI is low and we start them on heart failure therapy on the GDMT, ARNI, and everything, we expect that their VTI may improve up with the treatment. Right?
Absolutely correct, ma'am. Dr. Parashar used to always teach us
Yeah.
that whenever you are following a dilated cardiomyopathy patient, which parameter you will choose. So we
Yeah.
used to say we'll choose stroke volume. We used to say we used to follow tissue Doppler. We used to follow strain or
Hmm.
ejection fraction. But then the
Hmm.
ultimate answer used to be stroke volume, which is a product of VTA only.
Correct. And this fluid responsiveness is a very, very good thing, because generally it has been found that people who are overcorrected with fluids have poor prognosis in the critical units. So, non-invasively, where you can't do invasive, interventions and putting CVP lines and measuring the pressures, we can
Yes.
always do a VTI, and it is quick actually to take the VTI.
It is the quickest method, and ma'am, nowadays dengue patients need not have more fluids to be given. And here,
Okay.
if a patient with dengue hemorrhagic shock or some patient with any shock, it's BTA is the most helpful technique which we are using, and it is
Okay.
really gratifying, and it is giving us very good results.
Mm-hmm.
And
Hmm.
in fact, when we are weaning the patient from intra-aortic balloon pump, patient has
Hmm.
been put on intra-aortic balloon pump, we use this VTA, LVOT VTA is the only answer to give
Hmm.
us a chance to wean him off
Hmm.
if it is near to normal. If it is
Hmm.
not near to normal, we still keep the patient for IABP. We continue with IABP.
Hmm. 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 Hmm.
So it has
Hmm.
a lot more possibility. It has a lot more effect.
Yeah, so it is quite an important thing. We all must learn that, in our post-MI patients, in heart failure patients, cardiomyopathy patients, myocarditis patients, we must not forget to take the LVOT VTI to follow up such patients. And as Dr. Soni has also said that in the RVOT VTI also, in the pulmonary embolism cases or pulmonary hypertension cases, this is how we follow our patients and we come to know that they are in the bad prognostic, meaning the group is having bad prognosis. So I don't think that these are only academic indications. These can be very well used in our emergency situations and critical care units, and even otherwise also routinely when you're following your cardiomyopathy or heart failure patients.
Yes, yes, absolutely, ma'am.
Right. Dr. T.M. Agrawal, you have anything to comment? Dr. T.M. is probably, he joined, but Acha, Dr. Rohit, there are few questions in the chat box.
Okay, ma'am.
Yeah.
Uh, in the presence of frequent premature VPCs, is there any difference in the value of VTA calculation? So here we always suggest that you should average it. Whenever you have a irregular rhythm, you have VPCs, we should average these LVOT VTI by at least 5 to 7 cardiac cycles.
Yeah, and if there is an atrial fibrillation, again the rule of 5, at least 5
Rule of
VTIs.
5 or 7, you can
Yeah.
just average them and then divide by the number of beats, whatever you are averaging.
Correct.
And
And leaving the beat just after the premature PVC, we can always,
yeah,
take the normal ones.
and always we should reduce the gain. That is the main crux. That gain has to be reduced because we should not overdo the tracing. That is very important.
Right.
And we should forget the eddy currents related LVOT VTI. That is a bit of a problem sometimes. But otherwise, it's very simple. And then there's a question, ma'am. Can you please demonstrate as it where to place the the sample volume in 5-chamber view? So I think it's a very simple thing which has been commented in the PowerPoint presentation only, that we can put a color 5-chamber view, put a color Doppler, and wherever you get the laminar flow closest to the well, just or 3 to 4 millimeter behind, we should use.
Perfect.
Then, ma'am, there is a again question regarding atrial fibrillation that we have answered.
Yeah.
And nowadays, UPQS is not considered for evaluation. Okay, this is a bit of this is a very right question. UPQS calculation using LVOT VTA is considered a little bit inferior. But at least whenever we are considering a patient of moderate disease, it is still helpful. We are old timers. We are still using it as a UPQS calculation.
No, and I feel there's no harm in measuring it and assessing the need of subjecting the patient for closure.
Absolutely right. Absolutely. Whenever there is no chamber dilatation,
Yeah.
then these mayors give an additional benefit and telling us that the shunt is not actually a shunt which is significant shunt. For example, a patient who is having fibrated atrial septal defect, there are two to three small defects, and we don't know whether these defects are actually producing the right atrium, right ventricle volume overload or not. Then QPQS is this QPQS LVOT BTS are benefit. And yesterday only we had an abstinent patient. Abstinent anomaly patients have severely reduced pulmonary flow. And LVOT VTA is helpful to give us the actual stroke volume. So there only we have to rely on that because it's very difficult to give a proper ejection fraction. So again, LVOT VTA, RVOT VTA, both are so beneficial that I can't comment that they can be awaited in any examination.
Okay, there's one question coming from Dr. Mehboob Rahman. Can you see the question?
Yes, ma'am. As we know, planimetry of mitral valve area is the gold standard of mitral valve area. Here, why can't we use the VTA for continuity equation for mitral valve area calculation by using a LVOT stroke volume in every VTA? Okay. We all very well know that whenever there is mitral stenosis, there is a difference in the compliance of the left atrium versus left ventricle. So whenever there is difference between two chambers, these continuation based equations don't work well. So that is why we rely on planimetry rather than only LVOT, VTI, and these parameters based on continuity equation, which are Doppler based. And also, we already know that mean gradient is not very much used in mitral stenosis grading because of the same problem, that left atrial left ventricle compliance becomes deranged in mitral stenosis. So that is the answer which I want to
Yeah.
give. Answer, ma'am, can add a little bit.
Yeah, and I also feel, Dr. Rohit, that we should be actually going by a multi-parametric approach for any situation.
Absolutely, ma'am. Absolutely.
Not
Because,
just relying on one thing, that either VTI or mean gradient or planimetry or pressure half time. We need to understand that as many parameters which are fitting. Generally, there are situations which are very very clear. So everyone is fine with that. When there is a confusion,
yes,
I think the knowledge of other parameters does help sometimes,
yes. We can't
right?
make it mandatory. We can't make it mandatory.
Yes, yes. So we should be open-minded, knowing about these things, and whenever required, we should be able. Because if the mind doesn't know it, we will not try to look for it. So that is the idea behind discussing about VTI. And once
Yes,
we
sir.
discuss it, generally, most of us actually we try to finish off the study hurriedly. And once you know that, okay, this has been discussed once in the session, you might think about, measuring a VTI as a routine in such patients.
Yes, ma'am. And there is one more question now coming up. When to say LVOT obstruction? So LVOT obstruction, you can say whenever the velocity is exceeding more than 1.5 to more than 2 meters per second. That is what we take the criteria. Then we say there is underlying LVOT obstruction also.
Yeah. And in cases of LVOT obstruction, obviously the VTI will be abnormal. Okay, so these are the situations wherein we have to be careful that is it a kind of, hyperdynamic state, Takotsubo, hypertrophic cardiomyopathy, what are we handling?
Yes. And then we should make a Bicon 5-chamber view. And that view gives us the best view of the LVOT. And then we can arrange and we can say that yes, there is LVOT obstruction and we should avoid, then we should not take LVOT vision.
Correct. So the concept is that, we are taking the LVOT, the valve, and the aorta as a cylinder. Okay, so if the cylinder is distorted at any place, as in LVOT obstruction cases, due to any sigmoid septum or hypertrophic septum, so in those situations, the morphology of the cylinder is distorted, and now then we cannot extrapolate what we are talking. Is that okay, Dr. Rohit?
Absolutely okay, ma'am. The last question is just coming up is can we use mitral PTI to decide left atrial function? Okay.
Okay.
Left atrial function by mitral VTI is no longer recommended because of the same problems of atrial compliance, rhythm problems. Nowadays, atrial functions can be used by only pulse Doppler one, that is normal EA velocity what we are using. And secondly, strain has been very helpful in left atrial strain has been very helpful to consider reservoir, contour, and neutral strain in these patients. So we don't
Correct.
use microvol VTA. We should not use also.
And tissue Doppler velocity can also be utilized.
Absolutely not. The tissue doctor velocity of especially atrial systolic velocity A dash is very very
Yes,
helpful to give us a good amount of idea about atrial systolic velocity.
correct. You're talking about atrial reversal, right?
Atrial reversal is pulmonary and atrial A dash, that is mitral A dash is
Yeah.
atrial systolic velocity.
So can you more elaborate that?
Okay, when we take tissue doctor, we have three waves. One is S dash wave for systolic
Yeah,
function, and E dash wave is for early diastolic recoil, and A
right.
dash wave is for the atrial systolic velocity. So
Correct.
that A dash wave is a very good wave, And if we can take the reversal minus A dash, that also gives us a good point of view. But even if A dash we take, then it gives us a good amount of atrial systolic functions. So that
Correct.
we should take. That is my recommendation.
Yeah. So don't extrapolate VTI, mitral valve VTI
No, no,
for
no, no,
the
no.
LA function.
Yes.
All right.
Mitral VTI is very, very, it's very prone to underestimation, overestimations.
All right. All right. Correct. Any other questions or we move on? Reena just asks Dr. Saab if he is here
We are
available.
finished. We are finished with the question.
They have finished, they have understood everything. Thank you, Soni. Thank you so much. Let me search out Dr. Rakesh. Actually, I think we will at some point of time. There are few pitfalls actually, which I wanted to emphasize that the Dr. Rakesh Gupta has started. So we'll talk again later.
No, no, go ahead. I can listen to you also. Don't worry about
No, 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 no. Please go ahead. We have stretched 15 minutes because I could not
it. Yeah,
locate you.
I saw already. I like life is such a different nowadays. Like you just keep on running,
Yes,
Yeah.
yes. So I was just wondering, and
And I'll share a very good experience today. Just one person walked into Echo Lab and they said, "Okay, look, we are having a problem." So I said, "Okay, let's do it." And that lady was having acute infemoral MI and she was roaming around for last one day.
hmm,
ST elevation 120 by 80 BP, ECG normal, classical history chest pain. And everybody thought she's feeling because her daughter was getting engaged today.
oh,
And when we did an echo was classically showing the evidence of acute extensive anterior MI, inferior MI.
hmm,
And we took her to cath lab, proximal RCA lesion, 100%, and full of thrombus and everything. Anyway,
hmm.
and I
Anyway,
learned,
so the message is that don't get stressed.
yeah, don't get stressed, answer is if you are getting married or your daughter is getting married or son is getting married, let them get married or you get married.
Correct, correct. Doctor, over to you.
All right. So look, an excellent presentation. I must congratulate Soni Rungta and Dr. Hansa Gupta for picking out this topic very elegantly. And it is extreme uses. I'll tell you where do I use it in regularly. It's not there in literature. I see this utilization of LVOT VTI in patients who are presenting with DCM, dilated cardiomyopathies. The same ejection fraction will be variable if I'll calculate, Dr. Hansa will calculate, or Dr. Soni will calculate it. The LVOT will remain, the diameter will remain the same. You put a cursor in LVOT and see whether how the LVOT has behaved over a period of time. If it was 12, 9, or 10, and now it's 15 or 14, it means your LV has become definitely better than before. And I digged out this paper from Jack. LVOT outperforms ejection fraction and Doppler-derived cardiac output in predicting outcome of select advanced heart failure cohort. And this is where we have been starting utilizing. I absolutely agree with you. You did a wonderful job presenting the best in this LVOT. And the comments by Dr. Rohit was too good. Like, how do we utilize these things in clinical practice as on today? So the take-home message is we must utilize this particular modality in day-to-day practice. And whenever we see a patient who has got a poor LV systolic function, take my word, spend some time on this patient to get LVOT VTI. And that make you really, really more wiser than other people across the street and across the hospital. So moving on from this particular point and moving on to my topic of severe aortic stenosis, let me just share my previous slides where I talked about this particular modality. And still, this is the most sought after most discussed modality as on today as far as echo is concerned. And I would like to share this slide, which is more than 20-year-old and still it's valid. It's not gone away as it is. If you look at this slide, what exactly everything it talks of a continuity equations. The mere continuity equation, Mr. has clarified very categorically, it involves LVOT flow, the dia across LVOT, along with aortic valve VTI, LVOT VTI, and gives you a continuity equation, aortic valve area. Well, alone this equation may not be useful at many places. And the most important part where we discussed all these things was when we were talking about is a dimensionless index. If we have aortic valve area, which is variable, it is variable number of times, because if you happen to measure LVOT diameter, which I feel is the most toughest part of aortic stenosis evaluation, even today also. And why that is important? Because we have to have, if you look at this slide, if I'm measuring my LVOT diameter, by both of these leaflet, right cornicus and non-cornicus, should be really opened up, so that when we are cutting this LVOT, we are cutting at the level of, if I've got this picture, yeah, I should be cutting like this right into the center of this particular frame. Because what do we see? He is a right cornicus, he is a left cornicus. What we are cutting is a right and non-coronary cusp. And that should be the ideal way of doing this. And the best thing for doing it is when we see both the leaflets are opened up during early systole or mid systole, when we measure the exact dimension of LVOT. That's one issue. Second important thing is we should always look at multiple windows. I'm saying it again and again because majority of time we miss the other windows, and the most common thing is the right parasternal window. And one more window which we devised by Jrop is we call them as right anterior oblique view. Instead of putting a pillow behind both the shoulder, just put a pillow behind right shoulder only. Let the patient lean on the left hand side. And you'll be able to see a very beautiful ascending aorta in that particular window. And that's what is more important, because as soon as you put a pillow only on the right shoulder, this whole of the ascending aorta would be very clearly visible. Moving on further, then we talk of this particular phenomena of dimensionless index. Why we talk of this formula of dimensionless indexes? Look, what exactly has happened in this dimensionless indexes? We have a fixed LVOT area, and then we have a fixed aortic valve area. And that is prone to so many calculation errors, because what is the LVOT area is we need to have a dimensions of diameter of LVOT, and which is quite variable. If this would have been so specific, the people who are doing TAVR will always believe in LVOT dia calculated by echocardiography. They are not. And that is the reason, if you look at this dimensional index of 0.25 or less than that, is quite good or specific of aortic stenosis. And this has been amply said in this slide. DI value of less than 0.25 suggests severe aortic stenosis, especially when other clinical and echocardiographic parameters have become equivocal. We just did one patient of aortic stenosis, atherosclerotic, of course, where aortic valve area is less than 1, but when we did a dimensional index, it was 0.25. Gradient were not high, not the peak velocity. And obviously, patient was having left ventricular hypertrophy. The other option is we could have gone and did a planimetry of that particular patient's direct transesophageal planimetry, which correlates very well with the aortic valve area calculated by cath data. So what we did, we went on to get his LVOT diameter and got the cardiac CT done. And there was a significant variation between our LVOT diameter and a cardiac CT diameter. And when we calculated the cardiac CT diameter, his area of aortic valve was more than 1 centimeter square. So this is another take-home message for for people when you find a discrepancy, and this has been adequately said in literature about all these things. Now, other question comes is, one we look is transvalvular flow rate. What is this transvalvular flow rate is? This is stroke volume divided by ejection time. And this got a significant values when we talk of a transvalvular flow rate. Anything more than 220 is considered reasonably normal. Less than 220 is abnormal. And that is where it makes a lot of difference when we talk of transvalvular flow rate. These are the parameters which are useful when we are doing an echocardiography in dicey subjects. The word is when other clinical and echocardiographic parameters, they are not going in exact values. Next comes ET-AT ratios. And look at this paper, prognostic impact of ratio of acceleration time to ejection time in patients with low flow, low gradient severe aortic stenosis with preserved ejection fraction. And it categorically says these words. In conclusion, the association of this ratio more than 3.36 and all-cause cardiac mortality risk was consistent in subgroup of low gradient severe aortic stenosis and preserved ejection fractions. And it is an independent predictor of 0.36 is the independent predictor of mortality in patients with low gradient severe aortic stenosis. Now, question comes. This is
Doctor,
again.
मैं interfere कर रही हूँ. Can we just show them something like, what is ejection time and what is acceleration time
Sure.
briefly? Yeah, thank you.
So what is ejection time? Look, this is a Doppler gradient across aortic valve. So how do we do it? We take a parameter of timing onset of this Doppler spectrum pattern to peak of this Doppler spectrum pattern. Similarly, onset and end of this Doppler spectrum pattern. So that is one is acceleration time. Second is ejection time, AT-AT ratio. Very simple parameters. And I was coming to that point. What Dr. Hansa said was, if you look at this slide, again, 22 years old slide, you look at the Doppler parameters, morphology, gradients, cardiac output, aortic valve area. If they are adequate, we made a diagnosis already. If they are inadequate and discrepancy is present and poor LV systolic function is present, we go on to do a transesophageal echo in 3 dimensions. And believe my word, if you really ask me when I'm in doubt, what I always do is just do a planimetry by transesophageal echo. I say in number of conference, why we need all these parameters of low flow, low gradient, severe aortic stenosis, yes on that. Why don't you just put a probe inside and look at a planimetry area of the aortic valve area? And look, it's beautifully correlated. It's very well seen in this subject. Next is, before I go to the slide, I comprise that we have these 4 varieties of severe aortic stenosis. DI has not become valid in any of these. Aortic valve area is consistently less than 1 in all 4 varieties. Normal flow, normal gradient. Some people say high flow, high gradient. Then high flow, low gradient. Then low flow, low gradient. And then low flow, low gradient with poor LV systolic function. 1, 2, and 3, they have a normal LV systolic function. Here, the LV function goes down dramatically. If you think about this modality, this is it appears to be continuum of a disease. My aortic stenosis starts. Once the aortic stenosis starts, everything is like good LV hypertrophy, good contracting LV. And on top of that, the most important thing is gradients are good, aortic valve area is less than 1, the stroke volume is good. Then my heart start getting tired. So what does it happens? The stroke volume is preserved, the gradient starts falling down. I'm still more tired. So what happens? My aortic valve area remains same, but even the stroke volume starts falling down. And my gradients are gone, my stroke volume is gone. What else is left? My heart starts failing. And ejection fraction goes down. Unfortunately, we still stuck with the criteria of 52-54% ejection fraction. 52 in males, 54 in females. But if you develop a left ventricular hypertrophy, do you think the 54% ejection fraction is a real answer? If you go to JAC 2019 module of aortic stenosis, there's a special JAC publication during that time was, they said, let's modify the ejection fraction to 60%, 58, 59%. What exactly is happening from this point to this point? It means that the ejection fraction is 60-70% over here. Now ejection fraction has gone down to 60%. Now ejection fraction has gone to 55%. They're all normal. And here the ejection fraction has gone down significantly, is less than 50%. And that's what I always say is, whenever you look at aortic stenosis, please always calculate aortic valve area and dimensionless index. Just don't go and do it. Okay, look, the gradient is only 3, the velocity is not much, but spend time in calculating the gradients. And if I go back to this slide, which was done almost 20 years down the line, is when discrepancy is present and when you see these 4 formats of normal flow, low gradient, low flow, low gradient paradoxical aortic stenosis, especially in this particular format, 2 things will help you out. One important thing helping you out is look at a GLS. What is GLS? GLS is a global longitudinal strain talking of what? Subclinical LV dysfunction. It means somebody has got a 60% ejection fraction, but GLS is minus 15. Normal is, some people say minus is 18, minus 17, minus 20. Whatever it is, the average is minus 18. If my GLS is less than 18% in a very good contractile LV, and my diagnosis is low flow, low gradient severe aortic stenosis, then if my GLS is low, take my words, you have understood everything that this patient belongs to paradoxical aortic stenosis. And second thing is get a calcium scoring done. If the calcium scoring is 1400 or more, obviously think we are dealing with severe aortic stenosis. So answer is, when you get a severe aortic stenosis, you should always look for a certain parameters, and those parameters are very well important, and they need to be looked after by this particular imaging quality. LVOT VTI, LVOT diameter divided by aortic valve VTI will give you aortic valve area. Doppler flow pattern across those 6 windows, wherever the maximum is, the peak velocity more than 4 and the gradient more than 40. And index stroke volume against is like you calculate stroke volume divided by body surface area. If it's more than 35 cc, then you're dealing with normal flow or high flow, high gradient. Some people call it high flow, high gradient. Same you calculate aortic valve area, but the peak velocity and mean gradient just start falling down, and the index area remains the same, and index stroke volume is still preserved, then possibly you're dealing with high normal flow, low gradients. And finally, low flow, low gradient paradoxical aortic stenosis. And this is the most important thing. You may pick up all this. You can normal, this is very normal. This is still good. But the most important thing lies in this paradoxical aortic stenosis. Now the question comes, your area remains low, your gradients are less, your LV function has gone down. What do you do then? The answer is, what you should do is, you should give a dobutamine challenge, and that's still low dose dobutamine. Low dose dobutamine is, we start with 2.5, 5, maximum 7.5, or the max is 10 or not more than that. If it's a true aortic stenosis, the gradients will go up and the area will fall down. And if it's a pseudo, both things will go up. It means patient is not belonging to severe aortic stenosis. And that's my word is, it may be challenged by many of the people. What I'll always do is I'll just put a transesophageal probe and just look at a planimetry of the area of that particular patient. And I think this is what I was trying to say, that this is what we do at GLS. People who understand what is the GLS is, we acquire 3 different views, 4 chamber, 2 chamber, and 3 chamber. And rest of the job is done by a machine. So you acquire 4 chamber, good imaging quality. I'll say you can make a beautiful girl as a gorgeous, but not the other way around. Because if you'll give a poor echo windows to the patient or to the machine to calculate GLS, it'll be awful or it'll be haywire. I'll give you a polar map and I'll give you an average. Look at the average is only 14.8 over here. And virtually all machines have got a GLS. It's not really a rocket science as on today. And important thing is we discussed about transesophageal echo. And one more thing I want to discuss before I say close. The answer is where we do a calcium scoring. Now, many people they call up and say, sir, it's difficult to get a calcium scoring done. Only problem with the calcium scoring is majority of people, they do not have a software to calculate calcium scores. If the calcium scoring is not possible, and if you have a low flow, low gradient aortic stenosis, you have an option to do a GLS or do a planimetry of these subset of populations. Not going to make you like more difficult because many things are there in this issues. And when we have a lesion where LVOT obstruction along with severe aortic stenosis is present, that becomes really difficult challenge. And that challenge can be easily done again. People talk of so many things, but I can show you that challenge. I have a recorded case over here. The challenge was done very easily by doing just a transesophageal echo in that particular subject. And you know what was exactly happening? The LVOT gradient was not there. There was such a large hypertrophy that it was producing a so-called LVOT gradient reflecting to aortic valve. And when we did a transesophageal echo, there was nothing like LVOT gradient and patient was having a normal aortic stenosis. I think this is more than enough for this batch of a student. Love to take any questions because that is the most important thing which they will love. I would love to hear an answer. Dr. Hansa.
Yeah, thank you so much, Dr. Rakesh Gupta. It was wonderful, to know several things. But I also say that, in this such a situation, the last situation which you said, we can do this aortic planimetry or aortic this thing on even on transthoracic echo.
No, because that this is found that when we did a transthoracic echo, there's so much of a calcium and lumen stenosis is present. We are not able to get a good results out of it. And this
Okay.
was not correlated with the peak and mean gradients of catheterizations. Exclusively, we have to be in a planimetry by transesophageal echo.
Esophageal. All right. I think, I don't know why am I not seeing the chats. Any questions, audience? Or you have understood it all?
If you have understood everything, let me ask you a question.
That will be the right way. All the names are displayed. You can always take some name and then ask them, then they will start asking questions.
Look, learning has to be there on both sides, Believe my words, Dr. Mehbooba Rahman is asked, does it make any difference in value of VTI calculation, either mitral or aortic, if atrial fibrillation with fast ventricular rate specifically? Dr. Mehbooba Rahman, if Dr. Hansa allows me, I can answer this question.
Please go ahead.
If there's an atrial fibrillation, we understand that VTI calculation be very variable. How can you depend on a VTI calculation in atrial fibrillations? As we have been doing, like either you should do 5 to 7 or 5 to 11 sample volumes or correct atrial fibrillation first and then do a redo echoes. In our lab, like I can quote you, a number of time people come with atrial fibrillation and they want to certain parameters. We always say these are the parameters right now which are really fallacious. They are really variable. I just said in LVOT, if I'm making a diagnosis of severe aortic stenosis and there's a discrepancy in my area, I always write my calculated LVOT diameter is 2.17 centimeters, but it needs further correlation by cardiac CT. Similarly, if you have an atrial fibrillation and you're calculating VTI calculation mitral or aortic, first of all, atrial fibrillation majority of time, except in mitral stenosis, aortic stenosis, we hardly see any atrial fibrillations. Why we don't see it? Because it's atrial fibrillation is a problem with LA or RA. I don't say we don't see it, but we rarely see. But in mitral stenosis, we'll see atrial fibrillations. And atrial fibrillation in mitral stenosis, when we are looking at atrial fibrillation, maybe we need to calculate mitral valve VTI, but you can calculate VTI by taking number of sample volumes or the longest sample volume in a mitral flow, or ask the patient to hold his breath, the heart rate goes down, or you correct the heart rate first and do a VTI. Dr. Rahul Patil said QP-QS ratio is not considered for evaluation. No, Dr. Rahul. If we are doing like a pediatric echo, especially for VSD, we have to calculate QP-QS ratio. Because the classification of VSD is mild, moderate, severe, even though the gradients are not very high, is again based on QP-QS ratios. Dr. Sharmina Sultana was asking, how do we calculate QP? Very simple, Sultana, like go to a parasternal short axis view at aorta. Zoom up in such a fashion that you are able to see both the cusps, left and anterior. Look, there are two cusps are seen. On the left-hand side is left and the anterior cusp is seen. Look at the hinge point of those two cusps. Measure the RVOT diameter. Do a RVOT VTI. You get a QP ratio. QP. That is stroke volume across pulmonic valve. Dr. Pradyumna Godbole asked, can we use mitral valve VTI to decide LVA functions? No, certainly not, because my LVA function is this. It's a relaxation abnormality. So we are not able to decide that. And I absolutely agree with Dr. Rohit. Dr. Rohit very categorically said certain very important points. And we have to use this LVOT. It's a very simple thing. Instead of a continuous wave Doppler, and we have been doing that for a long time. Only thing is, we have to understand like where do you use LVOT flow velocity pattern. I showed you, it's not there in literature. I read this literature, I shared with you in JAC. And since then, all my reports going out of my lab, if they have a reduced LV systolic function, they go out with LVOT VTI. And normal is up to 24. I write in front of that, normal is up to 24. And maybe number of times your report shows higher LVOT VTI in poor LV systolic function. Think of a conditions which shows hyperdynamic flow, anemia, thyrotoxicosis. They are still common in our country. So you have to correlate so many things together in your life. And I say this again and again. I'm going to say this today also. Believe my words, echo will make you a very sincere physician. It'll give you a lot of money value. And you'll be far ahead of your colleague in your area. Dr. Rahul, you want to ask something? Your hand is still up.
Rahul Patil has written a question. Gupta sir, if with normal LV systolic function, having good Doppler tracing with the mean gradient MGPG, what is that, of AV suggestive of severe AS, will still be acceptable to label the severity of AS?
Dr. Rahul, if we have a patient, look, if you ask me the cornerstone of aortic stenosis, Dr. Rohit has also said the same thing. The cornerstone of aortic stenosis is not the gradients. The cornerstone of aortic stenosis is aortic valve area by continuity equations. Then peak velocity mean gradients, and then LV functions. If my velocity is only 2.5, 2.7, 3 meters per second, the gradient is 25, I do not see any LV hypertrophy. Fairly, and the age is 60 years or 70 years of age, I still start thinking of possibly atherosclerotic aortic valve. But as a practice, I always do my aortic valve area calculations. Maybe 1 out of 100 you will miss, you would miss if you will not do aortic valve calculations. And where this discrepancy is there, utilize dimensional index, ATET time, GLS. And that patient you can call again when you have some laser time. Somebody asked Dr. Mehboob Rahman, you said AS with AR. Why not? 100% valid. But if it's a MR, it will not be valid. Planimetry. All right. Questions.
Deepak Kumar is asking LVOT, VTI, and tower.
You mean to say like LVOT in post-tower patients? Deepak?
Deepak, please clarify.
Yes,
Yes,
sir.
sir.
He said post-tower patients.
Hmm.
Well, if you ask me LVOT in post-hour patient is, I'll not be the person to talk about LVOT in post-hour patients because in post-hour patient, majority of time, we are not looking at aortic valve areas. We are looking at peak and mean gradients and velocities. Dr. Kamal Malviya, when we suspect that calculated aortic valve area is something wrong, when you have a discrepancy of parameters, your aortic valve area is 1, but the gradients are low. Look at a DVI. Look at the clinical examinations. And I've not touched one more thing in aortic stenosis, not the third level of aortic stenosis, valvular arterial compliance. If that is an issue, in those cases, we have to go to valvular arterial compliance. Two things will keep on burning in echocardiography. One is diastology, second is aortic stenosis. They are not going to go away. And we have not learned anything from them till date.
I think they're exhausted with their questions, and so are we.
Oh, we are
And
not exhausted. You will get.
no, you are not exhausted. You never get exhausted. You are still booming with energy. You may still take their
But the
classes.
patient are sitting outside right now.
हाँ तो वही तो ये after this you will see the patients, but uh, I think we need to wind up now.
Sure.
And thank you so much for being here, Dr. Rohit. Thank you so much once again. And Reena, thank you so much for the logistic help always. And you guys being just keep registering for your early bird registration for the Eco Asia
Yeah,
2026.
you have that slide. Can you show them?
Yeah, Reena had, and we were displaying it before we started, but I think a lot of people have joined after that. Reena, if you could once again play that.
Just a minute.
Yeah, thank you, Reena.
It's a very simple registration fee. I'll share on this setup is we are holding the one of the best. Dr. Hansa is a chairman scientific committee. We are holding the one of the finest ACO meet in Delhi at Gurgaon from 8th to 11th of October 2026. Leela Ambience.
Yeah, and I've also asked them to, keep storing their good cases so that they can come for the case competition and
They
they can
should,
be
yeah,
addressed.
true. And you should be a part of this Congress. Try to show your energy, your lively cases. And I can assure you the registration fee for sonographers is, I say echosonologists, I don't call them as sonographers, is very minimal, 5,500 rupees with GST as on today. And if you get your sponsor, we'll reimburse it back to you. Same for delegates. 11,000 plus GST till 30th of December, 30th of November is bound to devise to 12,000 rupees with GST. And if you're getting some sponsor, all of you are doing a good practice. Get your sponsor, will refund your money after the conference. Because it will rise by 1,000 rupees every month. And we can assure you the best scientific program ever we had till date. And will be totally a clinical oriented scientific programs. I can give an example. I say echocardiography is there to manage heart failure, to diagnose heart failure, to treat heart failure, to prognosticate heart failure, to follow up the heart failure. Tell me which modality does this? Hypertensive subject LVH, diagnosis, treatment, everything is based on echocardiography. Diabetic, we'll have maybe 1 or 2 sessions similarly happening in next time is, let us show you what is the importance of echocardiography in diabetes patients who are asymptomatic, hypertensive subjects who are asymptomatic. And if you still want to read, just go to that paper just recently published in Indian Heart Journal, Stage B heart failure in asymptomatic hypertensive diabetes subjects.
It's very disappointing. Only Madhav Bansal has enrolled till now out
No,
of
no,
the
it's not
entire group.
disappointing. Everybody waits for the last minute and they want to pay 20,000 rupees. It's not disappointing.
Yeah,
They are always latecomers, you know.
correct. But they
हमारी
will be.
डॉक्टर्स की शादी लास्ट में होती है जब
हाँ.
नोटा अप्लाई हो जाता है.
Hmm. So, but anyways, it is encouraging that so many people have joined and joined us in this session, and we'll soon meet you all in December. And as Dr. Rakesh has said, utilize your early bird, this fee registration. Otherwise, it is going to be very expensive gradually. All right. Thank you everyone for being here. Thank you. Extra special thanks to Dr. Rakesh Gupta for this exotic advances in the aortic stenosis. I hope you all are benefited. Thank you for attending. And thank you, my moderators, as well.
And one more thing, Hansa, like we are making packages for even technicians also.
All
Maybe
right.
like next month we'll announce those packages.
Okay.
We'll give you an accommodation, we'll give you a registration. You just have to buy your tickets.
Yes.
So that'll be very valid. Like we'll know like where you can stay. And if you get a companion along with it, suppose 2 friends are coming, your package will be still low.
Correct.
In the same Gurgaon area.
Correct. I think we'll be able to even show all that, those packages in our next meeting, next session.
Definitely we'll try to show those packages
Yeah.
next week.
Yeah. And do let us know if any problems anywhere, we will try to sort it out. But do come and attend and, improve your technical skills.
We are there standing behind you all the time. Take my word.
Yes.
We'll hold your hand, but we want you to come and learn echocardiography in this next Echo India, Echo Asia 2026.